I don't know why you're here, John. I don't know why you're here. I don't know why you're here. You guys know. I don't know why you're here. You know all this.
You have motivated me.
You just want to see if I got any new videos.
Huh?
You want to see if I have any new videos.
Yeah. No, you're so much fun. Do you like it?
So well, unfortunately.
So I'm going to go ahead and start. Other people will probably be joining us. I've declined to be introduced because I'm so famous. No. I don't typically find introductions all that useful. People typically don't care where I went to school, although in this case, you might, because it was here. And so it is very nice to be back here. When I was an intern here many years ago, in the days of Ray Novak and Barry Morenz and John Mashashik, we had grand rounds in 84-03. So very similar room. You couldn't tell the difference. But it's very nice to be back here. I have always, in my entire career, stayed connected to the Department of Psychiatry. This is where I did my internship. This is where I did my postdoc. And they just couldn't get rid of me, kind of like Velcro, for better or worse. But anyway, that's my story. Let's see if this talk is relevant for you. And let's start with this. What are the kind of health-promoting behaviors you're talking to your clients about? When you're engaged with them for a consult, what are you talking about? What's your goal? What behaviors do you want them to engage in? Okay, that makes it a lot easier when you don't want your clients to do anything. You don't need them to do anything. You don't have to worry about motivating them. What are you talking to them about?
Sleep hygiene.
Yep, you want them to sleep better and spell better. Okay?
Stop smoking.
Yep. Right?
Poor choices.
You want them to make poor choices? You want them to make better choices, probably.
No.
Right? Better choices, like for, what would be an example of a better choice? Oops.
People.
People to hang out with, people to associate with. Right? Maybe what they do with their time. Right? What other kinds of things?
Weight loss?
Yep. Want them to lose some weight, maybe. Big implications for their health. Right?
Communicate directly.
Exercise.
Like with their partners, their family members, things like this. Right? So I'm going to put exercise up here with the weight loss one. Those oftentimes go together, of course. Exercise for weight loss is relevant, but exercise for, of course, mental health is relevant. So it could be multiple things there. What else? Anything else?
Take your medication.
Yeah, I was waiting for that one, given that I think there's one or two psychiatrists here, aren't there? And my guess is you want them to take their medication as prescribed. right? Not in some creative fashion that they looked up on the internet or in combination with grandmother's leftover medication from her back operation, yes? So, all right, so we got a pretty good list here. And these things you can call your short-term goals, your treatment goals. You can call them whatever you want. I'm just going to introduce to you a new word, target behaviors, just because that's what it's called in motivational interviewing. It's not a better word. It just shows you already know some things about motivational interviewing. You know what you're trying to help your clients do more often. Here are some other target behaviors that other healthcare providers have identified. This was at the annual conference for the American Academy of Pain Management. If you're in private practice, you'll recognize why that second one is important. And when you get to the bottom of the list, that sort of is the summary of the whole thing. And here's what our colleagues just down there on the main campus have identified that they want the students to do. Obviously, the students have a lot of eating disorders. They're eating too much or too little or not the right things or something. And here's what Arizona psychologists at their annual convention identified. So you recognize these things. These are the same kinds of things you're talking with your clients about. Here are some very narrow target behaviors for people that might have their first schizophrenic episode. So somebody comes in for a schizophrenic episode, what would you work with them towards? Well, maybe some things like this. Okay. Here are target behaviors identified by Community Partnership of Southern Arizona, one of the treatment agencies here in town, right? Notice again, they want their patients to take their medication as prescribed, right? Don't want to be yelled at, right? All right, so it's 4 o'clock here. We had a target behavior of exercise. Let's do a little bit. Stand up. Literally, stand up. You didn't know you needed a stretch break, but here it is. Okay. Don't drop your brownie. All right. So now estimate how many of the clients you see need more motivation to do the health-promoting behaviors like on the list we just saw. And if 5 out of 5 of your patients need more motivation, go ahead and sit down. All right, sit down if 4 out of 5 of your patients need more motivation. Yeah, look at that. Most of the people in the room are down. All right, sit down if 3 out of 5. All right, everybody in the room is down, either by fatigue or by this survey. And this is typically what we see. So this is a survey done at a San Francisco conference attended by people treating clients with HIV and AIDS. Basically, you're seeing that 76% of them are saying 4 out of 5 or 5 out of 5 of their patients need more motivation. Here's a conference attended by 680 primary care providers. They're basically saying 98% of their patients need more motivation. Here's a workshop done with case managers for a supportive housing situation. They're saying, again, basically 90+% of their patients need more motivation. So maybe that's why this kind of talk, this kind of approach is useful. Let's solicit from you some more things about your experience. So for instance, let's take one of those target behaviors, taking their medication as prescribed. Let's start on this side. What do your patients, what do your clients tell you about why they are not taking their medication, why they can't, why they don't think they should? What do they say to you?
Side effects.
Yeah.
Can't remember.
Costs too much. Doesn't work.
Okay. Other things?
Too much hassle.
I haven't filled it.
Haven't even picked it up.
Not needed.
Like, I don't need it. Yeah. I'm not crazy, I'm not depressed, I'm not... Right?
I thought I could stop because I'm better.
Yep.
I want to use a natural remedy.
Yeah, marijuana, that's natural. Okay. Other things?
I don't like to drink on my medicine.
You what?
I don't like to drink on my medicine.
I don't like to drink?
Oh.
On my medicine.
On my
I
mind.
wanted to drink alcohol, so I stopped the meds.
So they're actually practicing a health behavior there of sorts. Right? Okay. All right, so we've got a good list there. What about this side? What are some of these same patients, or maybe other patients, what do they say about why they are taking their medications, why they think they should, why they are glad to take it, why they're filling their prescription? What do they say on this side?
It helps.
Hmm?
Someone's forcing.
And it's not those voices in my head, it's the probation officer, it's the courts. That's right, yeah, good.
I don't want you to be mad at me.
Yeah. Yeah. Other things that clients say about why they're taking their medications, why they continue to take it?
I need it.
Yeah. I don't like it, but I need it.
I feel better when I take it.
Yeah, so it's sort of like it helps. I feel better, feel the benefit.
Worse when I don't take it.
Yeah. Okay.
I'm afraid to stop.
Yeah. I feel good. I'm not sure what will happen. I'll go back into depression, go back into a manic episode, go back into hospital.
My wife likes me better when I take it.
So she's not really forcing me, but life is a whole lot better, right? All right, so we got a good list here, both sides. So now here's a way to understand motivational interviewing that is both accurate in terms of perhaps explaining why motivational interviewing may help your patients find their motivation, as well as an explanation you can use to guide your consult with your very next client. If you want to use your motivational interviewing approach, arrange the conversation so the client says these things out loud. Don't you say them. If you said them, you'd be passing on very useful, accurate advice that the client would do well to listen to, but notice you would be active, the client would be passive. And who is it that has to be taking the medication? It's the client, right? So now this is based on a very robust principle that we think is true about all people, which is that we as a species believe what we say more than what we hear. So if you can arrange it so your client says these things out loud, he or she may be talking him or herself into the target behavior, taking their medication. Now there's another way to think about this that's just straight ahead behavior, which is after the patient leaves. Now, sometimes when the patient is having a consult with you, you may actually administer the medication. So for instance, if you're using an injection, if you're having them bring in their pills, you may actually observe them taking the medication. If you're down there on 2, you'll see them take their medications and so forth. But most times in an outpatient setting, you are not having them take the medication. And with most of the target behaviors we listed, like associate with better people and follow up on appointments, all those things don't happen during the consult, they happen later. So literally it's the client that needs to engage in that behavior, and if you can arrange the consult so the client engages in these behaviors during the consult, they're literally practicing the very behavior they need to do 5 minutes later, a day later, a week later, a month later when you're not around. So you're literally having them rehearse the very behavior they need to do later. They're the ones that have to think these thoughts, generate those thoughts, that focus, in order to motivate themselves to take their medication. Now those two principles, believing what we say and practicing the behavior, also apply on this side So you have to do something to manage that. You cannot just, I'm just going to ignore that. You got to do something. Now, one way to do that is to do exactly what we did here. Say it first, literally. Do not wait for your client to tell you these things. Use your empathy, use your expertise. You might know this client in particular. You may know these kinds of clients when you're working with this particular target behavior. So you could literally just say, well, you might not be taking your medication because you don't like the side effects. Now, if you're wrong, the client will say, no, that's not a problem. Great, you got that off the table. If you're right, the client may experience you as incredibly empathic and welcome you as somebody that finally understands why they don't take their medication. Once you've done that, once you've recognized this side where you've been in the lead, it makes it a whole lot easier to lead and segue back over to this side. Now that's motivational interviewing. That's it. Arrange it so the client says this stuff, manage this stuff, get back over to this side. Let me show you some other things you know about motivational interviewing. Look at these 4 statements, and with your colleagues, maybe sitting next to you, you can discuss what order you think they should be in. If they were to be placed in the order from lowest patient motivation to highest patient motivation, which one of these statements do you think reflects the lowest patient motivation? And then the next most motivation, and your last statement should be the one that has the highest patient motivation, you think. So just take a moment to think about that.
DBIC.
So that order that somebody was calling out there is often the order that most people will select, with the healthcare provider talking about why the health behavior is important and the patient verbally disagreeing. You might be able to argue that that's actually a more engaged patient than the patient that is saying nothing, because at least the patient that is disagreeing is trying to tell you, look, that won't work for me. The patient that is saying nothing is just waiting for you to shut up so they can get their voucher, so they can go home, so they can get, check their box off and they're done. But most of you probably selected C. The patient talks about why the health behavior is important and the healthcare provider agrees. Now, those may be rare, but that's the patient that comes in and says, shouldn't I be doing something besides just taking this medication? Don't you have some homework I should be doing? Is there a support group I should be going to? You know, like you can't wait to run out in the hallway and tell your colleagues about that because it's like, wow, listen to this. But that's what you're looking for. That's a motivated patient. And if there was a way to arrange the consults so it was like that, where the patient was talking about the reasons, the motivation, the healthcare behavior being important, and you just got to agree, would you be interested in that? There might be a variety of reasons why that would be interesting to you. One would be, I don't believe any of you got into this business to argue. Attorneys, I think they like arguing. We got some neighbors that are attorneys, and they just argue about everything. I don't know, that's just, they just like that, I guess. In healthcare, I don't think we went into this business for that. And I know your clients aren't coming to you. They're not going, hey, let's go up to that 7th floor. We can get into a good argument up there. They got some good people. No, they're coming to you for help or assistance, but they're not coming for an argument. And then, of course, it might be just patient outcomes might help us make a selection about whether that would be valuable. So, for this exercise, pair up. Just identify another person that you want to work with. And one person in that pair, make a fist. Hold it up. I want to see it. Only one person in the pair. This is the easy part, so if you're wanting the easy part, choose this one. All right. The other person in the pair, now do whatever you want to do. Do whatever strikes your fancy to get that person to open his or her fist. Do whatever you want to do. All right, let's get our attention back together. So whether it worked or not, what did you try? Whether it worked or not, what did you try? Asking, right? Sure. There's no rules against that, right? Everybody knew what you could just ask, right? Did that work? Probably worked sometime, somewhere, maybe, right? What else did people do?
Offering a brownie.
Offering a brownie, right? See, a little bribe. A little bribe, see, right?
Rock, scissors, paper.
Right, you play a little game, right? Sort of distract them, right? Very good, right? I love John Rossi, you know, he's such a vicious, violent character. You just can tell that he's over here trying to pry the fingers open. John, what are you doing? So that's a whole variety. Yeah, go ahead.
I told her that you wanted me to get her to open it, but I didn't really care if she did or not.
I see, little trickery there, right? Double message, very nice, right? Now, some of these things, do they sound similar to what we try sometimes with our clients? Sometimes we just ask them. Sometimes we tell them. Sometimes we try to force them. Look, if you're not going to do this, we're going to discharge you AMA. Sometimes we bribe them, right? We put them on a contingency management schedule if we want to be academic about it and so forth, right? But now think about a client situation where you wanted the client to be more motivated to do something. That's the target behavior. Keep in mind that's something. And now for yourself, by yourself, write down all the ways that you tried to increase that client's motivation, whether it worked or not, and whether it occurred over a single session or multiple sessions. Write down all the ways you tried to increase that client's motivation. You probably gave them some advice. You may have sort of made them feel guilty. You may have told them, here's what's going to happen if you don't do this. Here's what will happen if you do this. You, of course, listened to them. You probably used your empathy. You maybe explored the pros and cons. There's a whole range of things that you did. You make your list about what you did. At least get your list in your mind. And let's get a couple of those down here. So one at a time, just tell us what's one of those things that you did to try to increase your client's motivation.
Give information.
Yep. Yeah, give them information about the treatment, give them information about the medication, give them information about what will help. Sure. What else?
Practice it in session.
Mm-hmm. You could do some role playing, assertiveness training, these kinds of things. Sure. Drug refusal skills. What else?
Discuss the consequences.
Say more about that. Discuss the consequences. How do you discuss the consequences?
What if they continue to do what they normally do? What would happen if you get scared of people?
Yeah. If you don't treat this ADHD, here's some things that we know that typically happen with kids in school. They drop out, they don't do so well. See, that would be tell them some things that would happen if they don't treat their kids' ADHD. Yeah. What else?
Find out if it's something that they really want to work on to begin with.
Yeah. What is it that they're coming for? What is it would be important for them? The courts say, your wife says, but what do you say? What do you want to work with? Sure. What else?
Trust me.
You tell them to trust you. Hmm?
Only John Rossi can get away.
I know. That works for him. It does. What else?
Well, I give, thinking of a specific patient now, I give him a choice. You can have the alcohol, the wine you like at dinner, and put up with waking up at night a couple of hours after you go to sleep. Or you can stop having the wine and you'll probably sleep better.
Yeah, yeah. So recognize this is their choice. Yeah. Right. You're not the one that's waking up. They're the one that's going to choose whether they want to have the wine or whether they want to wake up. Yeah, exactly. Okay.
Challenge and erroneous belief.
Hmm. Can't believe I got away with that. Would have never guessed I could spell erroneous. Yeah, that's cognitive behavior therapy, right? A little mastery and pleasure therapy, a little cognitive distortion kind of stuff. What else? Now, of course, there's other things you're not listing, and it's very close to you because you do it all the time, but certainly you do this with your clients, you empathize with them, right? You come alongside them, those kinds of things. Anything else you want to put on your list here? So now I've been not only trying to spell here, but I've been trying to categorize these things, and I'm not sure I've done that correctly, but perhaps these are all things that are examples of a directing helping style. Directing helping style. There's the goal. There's how we're going to get there. Now let's go do that. Directing, okay? It's a helping style. It's very common in medical settings. It's the one you were mostly taught. It's the one that encourages you to ask diagnostic questions so you can learn what's going on, so then you can provide the treatment. So then you can sort of say, here's what we need to do. Here's the treatment. Here's the medication we need. It's a helping style. It's different than these kinds of things, which might be called a following helping style. Following helping style, you don't have a destination other than coming alongside, developing rapport, developing trust, sort of making sure that you understand who's in front of you. And directing, following, and in between that might be a guiding helping style. Guiding helping style has a destination, like a directing helping style, but you're not going to do the getting for the client. So it could be like a hiking guide. Hiking guide can be very useful, but the hiking guide is not going to carry you up the mountain. Right? Guiding style has the coming alongside, like the following helping style. You're going to come alongside them, look at their situation with them. Now, a directing helping style makes a lot of sense if you assume that the client just doesn't know what they need to know. They don't understand depression, they don't understand what's going on, they don't understand what this treatment is, so it makes perfect sense to then teach them. And oftentimes it looks sort of like this.
Is there anyone out there who still isn't clear about what doing drugs does? Okay, last time. This is your brain. This is drugs. This is your brain on drugs. Any questions?
That's a public service announcement that you all remember. That's a directing helping style. Another very common reason to use a directing helping style is if your client has anosognosia. Now, you know what that means. That means that they're just indifferent or they're lacking insight. Do you have your hand up or are you stretching?
Yeah. I picked a situation where I wanted to get my patient off of opiates or benzos, and this seems similar. I don't feel like they want to get off.
Yep.
So I tell them the risks of opiates or benzos, and my plan is to titrate them down. So it's not really their choice. I just want them along with me, and I want to encourage their motivation that they're not really feeling.
Okay, so now you're really saying an immense amount of information there. Notice, because you're the physician, you have control over some of their supply of opiates. So indeed, your plan will be implemented. So indeed, you're using a directing helping style, and you have to do that. You cannot, oh, I'll just give you whatever you want. You want this drug? I'll give you that drug. No, you have to do that, right? So directing helping style is a helping style that you as a physician have to use in many situations. You're identifying one of them where it would be risky, irresponsible to continue to prescribe at those levels. So it makes perfect sense to explain to the client, here's why, here's what happens, this is why we can't continue at these levels. Now, of course, what you're wanting is for them to go along with you. Interesting question would be, do they? Do they like your plan? Do they believe you're the one that went to medical school, how come they're arguing with you? You're the one that understands what opiates do. Why are they not? Oh, thanks, doc. Thanks for saving my life. No, they will argue with you. So this is exactly it. If you just stick with a directing helping style, you get stuck there. But you're right. You've got to use a directing helping style there. Right? Now notice, you're also identifying a client that may be indifferent to, well, I don't care what's going to happen down the road. I just hurt right now. I have pain right now, I'm not sleeping right now, give me those opiates, I want them right now, because if I don't have them, I can't go to work, I can't sleep, so I need them. I'll worry about, a year from now. I'll worry, about what's going to happen later. I'll worry about tolerance later, but I don't want to worry about their indifference to that. So in that instance, it makes perfect sense to try to inspire them, try to give them some little kick in the butt to sort of get serious about what's going on. And again, might look kind of like this.
If you are dealing with a mental illness, even though you may not like taking medication, even though it has problems with weight and side effects sometimes, please, please, please do that. Get appropriate help if you're feeling it slip away.
So if you're a TV celebrity, that may work, but for the rest of us, I'm not sure that's going to pay off a lot. Right? And if you are finding your directing helping style or your just following helping style is not getting you all the results that you might want, then that may be the time to bring to the forefront your guiding helping style. Directing helping style is a helping style. You will do a lot of informing, educating, teaching, advising. When you ask questions, the questions you're asking are typically so you get an answer, so you can make a diagnosis, so you can provide the right treatment. You will listen to the answers to those questions. A guiding helping style looks very different. You do much less teaching, informing, advising. The questions you ask are so the client learns, not so you learn for the file. So they're both helping styles, they just look very different. If you use a directing helping style, you will be tired and hoarse at the end of the day because you will be doing most of the talking. If, on the other hand, you use a guiding helping style, your clients will be doing most of the talking. This is one of the easiest ways to know if you're close to using a motivational interviewing style is just how much you talk. They're both helping styles. You use them with different clients, different situations. You use them within the same consult, but they are very different. Motivational interviewing can be considered a specialized subset of your guiding skills. It's something you already have. It's something you may not use as often as might be wise, but it's not something that's like discovering fire and thank God we finally figured out how to help people. And what difference would it make if you were to use a motivational interviewing style? Well, we have over 3 decades of research now with motivational interviewing. This is a summary of some of that research. This is a meta-analysis with 72 different studies included here. All kinds of different target behaviors there. And what you're looking at on the horizontal axis is the effect size, which you remember from your statistics class, is just giving you a measure of how much better or worse is, in this case, motivational interviewing than the comparison treatment, which in all these studies was almost always a directing helping style, an educational supportive style. So for HIV risk behaviors, you're seeing an effect size of about 0.7, which means your outcomes are 50 to 60% better. Drug abuse, public health, gambling, treatment adherence, alcohol, very respectable effect sizes, 0.4 to 0.5, 30 to 40% improved outcomes. Diet and exercise and smoking are not very impressive when we look 3 months after the treatment, but look what happens when we go 12 months after treatment. Not 12 months of treatment, 12 months after treatment is finished. Look at that effect size for diet and exercise and for treatment adherence. Those are substantive effect sizes. This is Bill Miller and Steve Rolnick, 2 of the authors, researchers, clinicians that are often associated with the field. I show you their pictures so you can recognize them and also see that they're handsome and they're white guys. And I say it that way in particular because if you use motivational interviewing with white clients, you get a very respectable effect size of 0.39. But if you have clients that are disenfranchised, if you've got clients from the lower socioeconomic groups, ethnic minorities, African Americans, Asians, Hispanics, people that don't get a lot of degrees of freedom in our society sometimes, you double that effect size. This is one of the few treatments that works better with the non-Yavis client. This is fascinating, and as you learn about motivational interviewing, you will figure out why that is. What do some of these studies look like? Well, here's one. Target behavior is participating in outpatient treatment after inpatient treatment. We have that. We got an inpatient unit. That's not the end of treatment. We need people to follow up. You see the demographics there. A lot of them are unemployed, a lot of them are African American. Comparison was between 5 individual sessions done in a motivational interviewing fashion versus the usual treatment, encouraging them to go to AA, supportive therapy, telling them the importance of AA and NA. And what do we see in terms of the percent still in aftercare program? 1 month, those that had the MI approach, 100% of them are still in aftercare versus 42%. 3 months later, 73% that had the MI approach are still in the aftercare program versus 8%. That is a large, significantly different effect. Here's another study. Again, attending aftercare appointments. You see the demographics there. These are clients that were involuntary admits, so they weren't wanting treatment. The court, somebody picked them up, said, you got to go. Right? Very short MI intervention, 15 minutes at the beginning of their stay, and then 60 minutes just prior to their discharge. Comparison was with the usual intake and the usual discharge, which would have been supportive, educational, encouraging them to follow up. What do we see in terms of the percent attending their first outpatient appointment? You see 42% with the MI approach attending if they had a dual diagnosis, 63% if they just had a psychiatric diagnosis. And here's the impact of that 15 minutes early in their inpatient stay. Now, I have not been on this unit for years and years and years, but all the inpatient programs I've ever consulted with or ever worked, they're not vacation spas. You don't get to get out of bed whenever you want. You don't get to sort of roll in and order breakfast at noon. Typically, there's structure there. You got to get up, you got to make your bed, you got to go to this group, you got appointments, you got these activities. So it's fascinating to me that we have most of the patients not attending the cognitive behavior therapy group. So they're doing something else, but they're not in that group. But if you just have 15 minutes of motivational interviewing, you double or triple the attendance during the inpatient stay for that cognitive behavior therapy group. What about decreasing drinking in people that have a schizophrenic disorder? You see the demographics there, most of them unemployed, many of them using other substances also. 3 individual sessions done across 3 weeks, done either in a motivational interviewing fashion or in a supportive, educational, give them some good advice fashion. And again, what do we see? The days drinking in the previous month. You see a steady decline in those that had the MI style and a later decline in those that had an educational style. This resource, Motivational Interviewing Assessment, Supervisory Tools for Enhancing Proficiency, is available to you in its entirety. You can download it from the internet. Just Google MIA STEP. It's also listed in your handout. You can just get it. It's not a manual to learn motivational interviewing. It's for supervising, teaching other people motivational interviewing. But it was researched in the Clinical Trials Network, which are various outpatient programs around the nation that take academic research and then take it to the front line. So literally, it was done this way with all clients, not just those that were depressed, not just those with an alcohol disorder, not just those using marijuana but not using alcohol. All clients that came to the outpatient clinic were randomly assigned to have the standard assessment, whatever that clinic used, or a little bit of motivational interviewing, then that same standard assessment, and then a little bit of motivational interviewing, like 15 minutes before and after the standard assessment. Then all clients went on to the same treatment program. Whatever the treatment program that agency was using, all clients got that same program. And what do we see? Those that had the little MI before and after the standard assessment had an increase in their attendance in the first month. There's your 20% increase in improved outcomes. Now, I think there's some parallels between medications for HIV and AIDS and psychiatric medications. You guys are in a better place to think if that parallel really exists. I think there's a parallel there because most of these patients on both sides are not glad to be taking these medications. People with HIV and AIDS are not glad to broadcast, oh, I'm taking my heart. They don't like people knowing that they're taking those medications. Most of our patients, clients, are not glad to know and have other people know that they're taking an antidepressant or an antipsychotic or an anti-anxiety. They may be glad that they work, they may be glad to be taking them, but I think there's a stigma associated with both of them. I think with heart in particular, There's a very high need to start early and to stay with it, as you well appreciate. You cannot start and stop these medications because the virus learns. You have to take them. They're very difficult regimens to follow several times a day, some medications with food, some without. So the client has to be very motivated before they start. And oftentimes you want to start these medications before the client feels bad. And when they start the medications, they get the side effects. So it's like, why am I taking this? I feel worse. So I'm just presenting these next two studies because I think there's some parallels there. I'm feeling okay. I'm sort of coping with my depression. I'm sort of coping with my bipolar disorder. But now I'm taking this medication and I feel worse. I'm not sure it's worth it. I think we got some similar parallels here. So here's one study. You again see the demographics there. None of them are in committed relationships. 12 years since their initial diagnosis. They're on 3 medications or more. Comparison was between 3 individual sessions done in this motivational interviewing fashion, where they also received some resources where they journaled and they talked about their experiences of taking their medication, versus the usual care, which again would be this directing, helping style, educational. Here's why it's important to take your medications. And here's what we see in terms of, in the last month, how often were you unable to take your medication as advised. And you can see a very clear difference. Those that have the MI approach are taking their medication as intended much more often. Here's a larger study, 134 people. You see the demographics again. 37% of these are living with their partners, about 8 years that they've been on their medication. Comparison was between an educational style or an MI style, 2 individual sessions, so both people get individual sessions. One group gets an educational, directing, helping style, another group gets the MI style, and again we see this typical kind of 20-30% increase in effectiveness. So that's some of the research about why this may make a difference. There are a number of resources that you might be aware of or you might like to be aware of. This is the most recent edition of William Miller and Steve Rolnick's book. This is sort of the standard textbook, if you will. The 3rd edition is about to come out, or will come out this year in August or September, I'm told. If you're really interested in motivational interviewing, I don't think you have to wait for the 3rd edition. The 1st and 2nd edition are different enough that if you really like this approach, they're both worth having. So this may be one thing. Hal Arkowitz over on main campus is the lead editor on this volume, which is using motivational interviewing to treat psychological problems, depression, anxiety, eating disorders. David Rosengren published this workbook in 2009, focused on literally, here's some exercises to do with your peers and or just by yourself to enhance your MI skills. Silvio Narking out of Detroit published this book focused on working with adolescents with this style. Let me give you a little bit more of a feel for how this actually sounds with clients. And instead of being the only expert in the room, it means you're going to emphasize collaboration with your clients. So many times a directing helping style can be thought of as a push technology. I'm trying to push knowledge into, push motivation into, inspire the client to do something, versus a pull approach. So instead of describing the specific benefits, I pull, I ask, what might be the benefit of doing the health promoting behavior? So the target behavior here is staying in high school.
Well, if I'm just going to get a job, I mean, the stuff I'm learning or that they're trying to teach now isn't really matter at all.
Especially that English stuff. I don't need any of that grammar stuff at all if I want to get a job or anything. So obviously he has got reasons for not staying in school. He's saying, look, it just doesn't matter. It just doesn't make any difference for me. I don't need to stay in school. It's not fun. I don't enjoy it. It doesn't teach me anything. Maybe, I don't know, but maybe there's something else in there, desire. So literally we could use our directing helping style. We could truthfully tell him, you will be able to get a better job if you graduate high school. That's the truth. He would do well to listen to us. What do you think? Does it sound like he'd listen to that if we said that? Maybe not. Maybe we could use our guiding helping style. You might like to learn something that really matters. See, I'm pulling on what he may want. I'm picking up on what he wants, not his reason to drop out of high school. I'm picking up on you'd like to learn something. What stuff could you learn that would matter? I want him in the lead talking about why he should stay in high school. I don't want to talk about why to stay in high school. I want him to talk about that. So I'm fishing for him to talk in response to these two questions, which may get him to talk about staying in high school. Instead of taking over the client's life, we could respect their autonomy. We could give them a choice, just like you said. We could let the client know that we're respecting their autonomy. So instead of telling him or her how to do the health promoting behavior, we could ask them, how might you do this so it fits into your life? This is a client who has a co-occurring disorder. Target behavior is doing things that would take care of his symptoms.
Well, I got to adjust to life. I don't know how to live life without alcohol. But I didn't know what's going on. Since I was a kid, I felt the same things that I feel now. When I was a teenager, when I was younger, but I didn't know what it was. I could live with them. Now it's almost impossible to live without doing anything about it. The depressions, the anxiety, and panic attacks, and all of that stuff is very paralyzing.
So on one hand, he's saying, look, I just can't live without my alcohol. I just don't know how I would do that. And these symptoms are so paralyzing, I have to do something about them, so I have to drink. I just have to do that. But also maybe in there, notice he's saying he has to do something about it. He may not like it, he may not be sure he can do something about it, but he's saying he has to, and maybe also the paralyzing is also a reason to try something different. So again, we could use a directing helping style. Your mood disorder will do better without alcohol. That's the truth. He would do well to listen to that. Maybe, however, we could come in more gently. You want to adjust to life without alcohol. I don't think he'll argue with that. It's time to do something about the symptoms. He's already said that. We're reinforcing that. We want him to go farther down that pathway. You probably have some ideas about what to do about the symptoms so you wouldn't be paralyzed. Notice I'm wanting him in the lead about what he wants to do. I don't want to tell him what to do, even though I have good ideas. I want him in the lead because he's the one that's going to have to actually implement those things. Instead of emphasizing how important it is for the client to do it, we can ask, why is it important for you to do this? Target behavior is stopping his drinking.
Well, I got in trouble from university for being underage and drinking in my room. So I'm pretty much in trouble at the university. I've been caught in my room drinking with my friends. That's the reason I'm really here today.
So obviously he has not come to the Student Health Center to get help. He's come there because somebody has said, you're in trouble. We busted you. You got to go to this program. He's not glad about this. He may not even think he has a drinking problem. So we could say this would be the truth. He's underage, not only trouble with the university, but it's illegal for you to be drinking anyway. He'd do well to listen to us and his parents, who are probably saying that very same thing. We could also poll. What benefits might there be for you, if any, if you changed your drinking? Now, I don't know what he's going to say. He could say nothing, or maybe we might hear something. He's a college student. We're hoping he's bright. He might be able to identify some things that aren't going so well with his drinking. Sounds like you don't really want to be in trouble with the university. I want him to talk about that. I want him to talk about what he does want, what he wants to have as experience in college. Okay? I'm pulling for those things. So there's several catchphrases you might use to remind yourself to use your motivational interviewing skill. Quit your job. If you think it's your job to get your client undepressed, unpsychotic, to stop hallucinating, to come back in for appointments, guess whose job it's not? Quit your job so your client can do his or hers. Instead of taking over the client's life, just get on the bus with him or her. And I'm not talking about mass transportation. I'm talking about just come alongside the client as if literally you're riding alongside the client. Look at his or her life with him or her so you can see their dilemma and ask them what they would like to do about that. Go fishing for their motivation. You're very likely to find it. You're very likely to find their motivation as you respect their autonomy and as you collaborate with them. All right, let me pause here because I'm talking a mile a minute. We're almost finished with our time, and maybe you have some questions. Maybe you just want more brownies.
Is there any thought or intent to let what you know about the person's personality, for example, the degree of their dependent needs versus their autonomous strivings. That was one idea. Their need to go along versus their need to oppose. These different kinds of personality aspects in different people. Because it strikes me that it's probably, it wouldn't work to be a one-size-fits-all kind of thing. And I'm wondering if you try to adjust your approach based on what you know.
Yes, I think you would certainly do well to use your expertise. So when I say quit your job, I don't really want you to give up all those wonderful observations and all that diagnostic ability. I want you to act like you don't know, but I want you to pull. If you want to use a motivational interviewing style, you want to pull for the client to know those personality characteristics that you're describing and to be able to modulate them or be able to access them and use them as opposed to you telling them. That would be a directing style if you told them, but you could use your knowledge to say, what do you know about yourself in terms of how you handle these situations best? How would you go about this so that you could feel the best and get your needs met, knowing what you know about yourself? Now, if they don't know, literally, if they come back to you and say, I don't know, I don't even know what you're talking about, you got a perfect opportunity. You're going to put down your guiding style. You're going to put on your directing, helping style. And you're going to say, well, it seems like from what we've worked across the sessions here, seems to me you got some dependency needs that you could get met here. What do you think about that? So you're not going to withhold your expertise, but you want to give it to them after you've created an interest or an opening for them. So yes, very much you want to use that.
Constantly, it sounds like a constant approach of turning it over to the patient.
Yep, right. It's a dance, right? Very much that way. Question over here.
What are the thoughts about why the effect size for smoking is so much smaller than substance use, like alcohol and other drug use?
And the thinking on that is that meta-analysis was done when most of the smoking studies using motivational interviewing did only motivational interviewing. So we bring the person in and we just do motivational interviewing. We don't use patches, we don't do any cognitive behavior training, we don't do any relapse prevention. Now what's interesting about that, that's not how motivational interviewing is used any place else. So motivational interviewing is not used as a standalone treatment for substance use. You don't just use motivational interviewing, you use motivational interviewing before they go to the treatment program. So the more recent studies that have done that, where they do motivational interviewing and include all the other things that oftentimes are found helpful with smoking, find a bigger effect size. But early on, the studies that you were seeing reported there just did motivational interviewing. And that might have worked maybe in the 70s when we had a larger percentage of people smoking. But the people that are smoking now want to smoke because you can't do it here, you can't do it there. So those people are very attached to their smoking. You're going to need a whole range of resources to help them. Motivational interviewing just increases their participation in using those resources. So this is the effect you're seeing with that MIA STEP study. There were 8 clinical trials that implemented that. They're all different programs. They had different intakes, they had different treatment programs. Why did it increase the participation? Because they participated more in whatever that treatment program was. So I think you could expect to see the same kind of effect if you included viable treatment options. Just increase the client's motivation before you go to the treatment.
Why is there such a striking difference with white and Caucasians and minorities?
I think
because my other question is, what's the active ingredient? What actually is at work here?
We don't quite know what the active ingredient is. It does relate somewhat to what I showed you early on, which was the things you want your client to say out loud. So we have very interesting research, including research now done with functional MRI showing real-time changes in the brain, that when people think about the health-promoting behavior, they are changing literally their brain, which should not really surprise us. So that's one of the active ingredients. But one of the other supposed active ingredients are things along the lines of this collaboration. And the reason why I think it works better for the disenfranchised is because they have fewer degrees of freedom. They are so often treated by other people with a directing helping style. Shut up, sit down, go here, do that. You don't have degrees of freedom. I'm telling you what to do. So now you come in, particularly you come in, as in here we are in this tertiary care hospital, you know, the Mecca for Southern Arizona. You come in, 7th floor, and you collaborate with them. Instead of treating them as one down, treating them as you're the expert, you're going to tell them what to do. You treat them with collaboration. You may get a very large bump in that because they typically don't get treated that way.
You know, there's an old joke told about Carl Jung, that he went to Edinburgh once to give a talk. So he was invited to the psychiatric unit, and of course all the chronic patients were trotted out. There was a gentleman there with catatonia who apparently had not spoken in 30 years. So Jung comes up to him and says, "Good morning, Mr. So-and-so, how are you doing?" And the man said, "You're the first person who said a decent word to me in 30 years.
Yeah, there it is. I think that's it. You got it.
Which I think is what you're saying.
That's exactly what I'm saying. Another question?
When I was in medical school, we did just a little bit of motivational interviewing, and it was all about stages of change and those kind of different stages you go through. And you didn't mention anything about that.
That's because you didn't do medical school here. No, I'm just kidding. That's often the case. Stages of Change by Carlo Di Clemente and others grew up at the same time as motivational interviewing. They were actually published in the same volume at the same time. They were both addressing substance use. A lot of people confuse them, put them together. There's published materials that equate motivational interviewing and stages of change. They are not. They are two separate models. You can see parallels. Stages of change is a very useful way to think about research, to think about materials you might want to send somebody after you have some questionnaire responses from them. But stages of change does not give you what are you going to say next. The patient just said this. What are you going to say next? Just because you know the client is in pre-contemplation doesn't tell you what to say next. It tells you don't give them advice. That's useful, but it doesn't tell you what to say next. Motivational interviewing is a much more useful tool, I find, in terms of the client is right in front of you, real time, has just said something. What are you going to do? What are you going to say? That's where motivational interviewing seems. But they're very similar. They both have similar goals, increasing the patient's motivation. But stages of change is more theoretical, more useful for programs that are asynchronous, meaning you fill out a questionnaire and then I look at that questionnaire and I give you some materials based on your responses. Motivational interviewing, real time, next response, here's where I'm going. Yeah. John brings me in to the medical students, and I don't know, did I ever teach stages of change? I might have done it years ago, but I typically do not teach stages of change now with motivational interviewing.
So I work with patients who have cirrhosis of the liver, and their motivation at the time that I'm doing my interview with them is to basically live and also to get a new liver.
Yep.
And how would you work with a patient after they have a new liver in terms of motivational change when now there's a whole nother reason not to drink?
Yeah. I've actually consulted with transplant programs with this issue, and the first issue before pre-transplant, I don't think you can do anything. They got a gun to their head. What are they going to say? Now, no surgeon will transplant a liver if the client says, "Oh yeah, I'm going to continue to drink." So what's the right answer? You know, no patient literally is going to say, "Well, I'm not really sure. I think I could drink moderate." No, they say, "I'm never drinking again." So before the transplant, you just can't work with that. Although I think you can get out ahead of that. Literally, while they're waiting for the transplant, I would say that to them. I would say to them, it's almost impossible to really know how you're going to feel about drinking now, given you're facing a death sentence. But let's imagine what's it going to be like afterwards. Now, you're going to be really optimistic now. But literally, all you're doing is you're laying the groundwork for when you talk to them after the transplant, and you want to then have their words to say, "So now, what do you think about this? You said this. Remember, before the transplant, you said it was going to be really important for you not to drink, so here you are. You're not really out of the hospital yet, but you're going to be released. What are you thinking about? Here's what you said. Look, I literally wrote it down. What do you think about this now?" So I would then sort of take them back to those statements, not because they were really true, but now because they may be important for them to remind themselves of that and have them actually reinforce those literally out loud while you ask them, why would you do this? Why do you think it's important not to drink? Why wouldn't you not test out your shiny new liver and see whether it metabolizes alcohol okay? Why not just go back to the other way you were, you know? So that would be what I would try. Does that fit in terms of your experience? You got?
I think it makes a lot of sense. In terms, I don't have as much time as I could use post-transplant, but your argument helps me argue more for more time after.
Right, pre-transplant, I just don't think you can do anything that is substantive. There's such a external motivator out there that they can't access. Motivational interviewing is pulling for internal motivation, which will easily be overwhelmed by a lot of external motivation. So there's a lot of external force, motivation on those clients. I don't think it's possible for them to notice their internal motivation. You can sort of dialogue about it, but I think really what you're doing is laying the foundation for afterwards. And yes, it's after the gastric bypass, it's after the transplant that people need our services, and it's unfortunate that they're not using us more often. I mean, we're the people that could do it.